My name is Nicholas Schiff, and I'm going to present a single case for you of a zolpidem-responsive patient to illustrate this phenomena. This case is a 45-year-old male who suffered a very severe traumatic brain injury 5 years prior to the study, secondary to a fall from a ladder to a concrete surface. The patient, when we saw them, ranged in their CRSR total scores from 10 to 14 points. In the off-drug state, the patient could be stood up and transitioned from bed to wheelchair with assistance. The patient could not stand on their own and make the transition on their own. Showed no verbal response spontaneously or with prompts, but was occasionally able to follow simple commands, but not all the time. In addition, there was preservation of automatic motor behavior. So just to show the patient, here's an example of CRS motor score testing. As you see, the patient is able to hold the comb, but doesn't make an attempt to show the functional use of the object. Of note, this patient is right hand dominant, and the resting right hand there was showing a tremor. Despite the fact this patient can spontaneously move the right hand, there's no effort to make a right-handed movement. This is with both the spoon and the comb. On zolpidem, this is approximately 45 minutes to an hour after the ingestion of the drug, or what you see initially here is a postural change. The patient is seated more vertically. Although the eyes are obscured for anonymization, you can see that the head is turned toward the examiner. When she presents the comb, we see that he takes it with the right hand, which no longer has a tremor, and easily demonstrates the functional object use. So unequivocally, this is a move from 5 to 6 on the CRS score, and we see quite a lot of organizational movement and difference in the interaction with this patient in this very short period of time. If we can look at the EEG. In the off-drug state, this patient's EEG is dominated by an intermittent bilateral theta rhythm, which you can see in these low-frequency waves over the left, right, and central EEG leads. This is replaced by high-frequency beta activity. And when we look in a power spectrum, we can see this dominant theta peak suppresses on the drug, and the beta activity emerges. This occurs over almost all leads, but is more frontotemporally dominant. And we've seen this in not just the patient that I'm showing you here, but in patients who've had other types of brain injury and show zolpidem responses. One other interesting feature in this patient and all of the other patients was that there's a very tight narrow band oscillatory frequency that emerges in each of the off states, and this peaks around 7.5 hertz for 2 of the subjects in this paper, around 7.4 hertz in fact. And this is a hint that perhaps this is due to intrinsic oscillations arising from layer 5 pyramidal cells, which are known in settings of slice conditions, which are very severely deafferentic conditions, to oscillate at just this frequency when small current pulses are given to them. A small current pulse lasting a few milliseconds can produce 4 seconds of this type of oscillation. Another hint that this mechanism might in fact play a role is that coherence in all of these subjects in the low frequency rhythms was very high and then suppressed on zolpidem across all channel combinations. This would be an example of what Christian Huygens in 1665 called the clock principle, where weakly coupled oscillators tend to emerge with a single coalesced rhythm. And if you're interested in this, there's a book chapter, and there are several papers now. There's a Nature Reviews neurology paper by Brian Edlow that goes over some of these ideas and ties them together with the mesocircuit model for how all of this might fit together. And thank you.
Hello, and welcome to this session entitled Neurostimulants, Drug Therapies, and Disorders of Consciousness. My name is Paula Sakuchi, and I'm a clinical pharmacist at St. Michael's Hospital, Toronto, Canada. And I work in the Trauma Neurosurgery Intensive Care Unit, and I've been there for over 16 years. I do not have any financial interests or relationships to disclose. During this session, we will define neurostimulants, review the role of neurostimulants in disorders of consciousness in traumatic brain injury patients, review efficacy and safety of select neurostimulants, and discuss the future direction of neurostimulants in this patient population. Neurologic injury causes significant death and disability worldwide, and examples of neurologic injury include traumatic brain injury, anoxic injuries, and stroke, with TBI as the leading cause of disability globally. In Canada, 2% of the population lives with a TBI. There's about 18,000 hospitalizations for TBI each year. According to US population data, their 5-year outcomes of persons with TBI are the following. 22% of patients have either died or stayed the same. 26% of patients have improved, and 30% of the patients have become worse. Why it is that brain injuries have different outcomes really depends on the location of the injury, the severity, and any history of previous brain injuries and age. And every brain injury is unique, and the impact of its effects to each person are different. Disabilities that come from a brain injury have direct impact on functioning, both physically and cognitively, and they can be classified into 4 main categories. The first category of disorders of consciousness, which, as you know, is the focus of today's discussion, and that's where we see severely altered arousal and or awareness of self in the environment. Other potential disabilities that may develop include neuropsychiatric, neurocognitive, and neurobehavioral, and patients may develop one or more disabilities. There are targeted therapies that we use to help improve and manage these disabilities. TBIs are associated with a cascade of secondary negative effects on both the brain structure and neurotransmitters. One or more different neurotransmitter networks may be effective. It really depends on the location of the injury. We use pharmacologic agents off-label to reverse some of these changes by increasing concentrations of neurotransmitters, such as dopamine, serotonin, norepinephrine, and acetylcholine. It becomes very clear then what the expected proposed role of these neurostimulants are. They restore the balance of neurotransmitter networks that have been damaged at the time of injury. They facilitate the return of consciousness or arousal, and to help them integrate and participate in their care by maximizing the rehabilitation of cognitive, behavioral, and or psychiatric functions. The following is a list of the class of medications that can be used to improve disorders of consciousness, and we'll be discussing all of them. Most of the medications and the evidence for use of some of these pharmacologic agents is related to stimulation or arousal. But many of these agents may also have neurobehavioral, neurocognitive, and or neuropsychiatric benefits. For example, amantadine may have benefits in not only in arousal, but also neurobehavioral and neurocognitive effects. So we may see enhanced arousal and wakefulness in the patient. In addition, we may see some attention and memory changes and motor processing at speed. I'd like to share a case that we've seen at St. Michael's Hospital in the TNICU, where we used a neurostimulant. We will use her as an example to highlight our thought process in this topic. SH is a 25-year-old female that sustained a high-velocity motor vehicle collision on the highway, and she was found at the scene unresponsive by the emergency medical services with a GCS of 5. She may have seized at the scene. Her injuries were severe multi-compartmental TBI with midline shift, and her MRI report indicated a diffuse axonal injury. After being heavily sedated for refractory intracranial pressures with high doses of sedation, at day 15, we were finally ready to assess and wake her up and see. The team asks on ICU rounds, may the patient benefit from neurostimulant to improve her neurologic function? With all medication choices, we always have to assess the risk and the benefits. We have to see what information we have about the medications. What do they do? What are they going to do to work to help? When should we start this medication? Are they on any infusions? Are they off sedation? More specifically, are they requiring neuroleptics, which could potentially counter the effects of the proposed neurostimulants? And then we have to think about the safety concerns. And a factor in the selection, the appropriate agent in part is dependent on the patient's clinical state and the timing post-injury. We have a selection of agents that we could consider using if the patient is in the acute phase within a month from their injury. And we have a selection of agents we could consider if they're in the chronic phase, greater than 1 month from their injury. I'd like to review each neurostimulant option individually. Let's take a quick look at amantadine, which is effective for both acute and chronic effects and disorders of consciousness by accelerating arousal. And this is really the primary reason we use it at our institution. It also improves elements of cognition, and amongst experts is surveyed as preferred agent for agitation. It also improves dyskinesia. Health Canada recommendations of pharmacologic management of TBI impairments do recommend its use as a considered option to enhance arousal and consciousness. The Disorders of Consciousness Practice Guidelines also advise clinicians to initiate amantadine to accelerate functional recovery and reduce disability early in recovery. Its mechanisms are direct and indirect effects on dopamine neurons, both presynaptically by increasing dopamine release and delaying its reuptake, and also works postsynaptically. It is also felt to be a weak, non-competitive NMDA antagonist, which may have neuroprotective effects. Its therapeutic effects are thought to be more gradual in nature. In terms of its adverse effects, its side effect profile is generally felt to be mild, and the effects are dose dependent. There is a potential risk to lower your seizure threshold. However, there is RCT evidence that has shown comparable incidence of rates of seizures in the placebo arm. And due to its stimulant effects, we may see some effects on sleep-wake cycle. And so to mitigate that, we administer the medication during waking hours. And that hopefully will prevent the use of sleep aids and other sedative agents. I have included a summary slide of select studies after each medication, which is for your reference. And after we discuss each individual agent, with our final agent being amitriptyline, we will summarize and compare the level of evidence for all of the medications. Zolpidem has paradoxical improvements in disorders of consciousness. It's thought to work as a GABA A receptor subtype as an agonist. And its therapeutic effects are thought to be abrupt and quick. You may see benefits within the first 10 to 60 minutes, and they may last up to 4 hours. While most of the time and most of the study I've seen have been single doses of the zolpidem, there are reports of patients that use use the agent multiple times a day around certain activities of daily living. And although we don't really have reactions that are defined for this particular indication, we know that there may be potential for abnormal dreams, headache, nausea, disorientation, and anxiety. Bromocriptine is thought to improve arousal in patients as well as cognitive and physical improvements. It also works at the dopamine receptor, D2 receptor as an agonist and D1 receptor as an antagonist. Its therapeutic effects are thought to be more gradual, as is amantadine. And usually due to its dose-limiting side effects, we would recommend that we would start with a lower dose and gradually increase the dose. Levodopa-carbidopa acts to increase dopamine levels by crossing the blood-brain barrier, and that's where it is converted to dopamine. Its therapeutic effects are thought to occur within the first couple of weeks. Just exercising cautions in patients that may have impulse control disorders. Adverse effects aren't too dissimilar from other agents that we've previously mentioned. Methylphenidate is thought to improve neurocognitive and motor function. It is also one of the agents that is listed in Health Canada's guide to the management of TBI impairments, to potentially given in patients that have impaired arousal and attention that is suspected as a factor in their agitation. It also works as a dopamine receptor antagonist and increases dopamine and norepinephrine and serotonin. Due to its stimulant effects, we try to administer this medication during waking hours, and that will hopefully mitigate any potential disturbances in sleep-wake cycles. Modafinil, its mechanism is not entirely understood, but it is thought to increase dopamine by blocking dopamine transporters and increasing norepinephrine and serotonin without any direct sympathomimetic activity. Its effects are not very well described in this patient population. However, we see this drug tends to work fairly quickly for its approved indications. I would exercise caution in patients with cardiovascular disease. Sertraline promotes cognitive function and motor recovery. It increases serotonin reuptake in the presynaptic neurons. There is some controversy as to timing of initiation, as during the chronic phases, we see downregulation of serotonin. That may be the ideal time to initiate therapy. Its onset of effects are delayed and gradual, as is some of the other agents previously discussed. Please monitor QT prolongation if on other QT prolonging medications. And finally, amitriptyline works to increase serotonin and norepinephrine reuptake into the presynaptic neurons. Its case report indicates that the therapeutic effects onset within several days. Please ensure you monitor QT prolongation and extreme caution in elderly patients. So in our assessment, in our summary of our neurostimulant options, I'd like to review each individual agent very quickly. Amantadine, you can see, has the most robust evidence. The evidence hasn't always been favorable, particularly in earlier studies. However, there is a trend to improve functional recovery and arousal. Zolpidem, on the other hand, has several case reports and case series that are very favorable, but more controlled settings are less favorable. Bromocriptine has retrospective evidence. The evidence is very limited in regards to arousal. Levodopa-carbidopa has case series case reports with a trend toward benefit. Methylphenidate has no conclusive evidence in regards to arousal. However, there is RCT evidence that may improve length of stay, both for hospital and ICU. May be considered as a secondary agent. Modafinil has no current evidence for its use in emergence for impaired consciousness. There could be a benefit in regards to excessive fatigue and sleepiness. Sertraline has randomized prospective evidence, but there's no improvement in arousal, especially when medication has been taken within a 2-week time period. But there may be some benefit in behavioral syndromes. And amitriptyline has case series, case report evidence, and improvements in arousal were noted for those particular studies. So it becomes very difficult for us to compare the neurostimulants based on the limitations of the current evidence. You can see with the study design, the heterogeneous patient population, the small sample size, doses of treatments and durations and timing of initiation are all very different, which makes it very difficult to compare. So when we select a neurostimulant, we certainly have to consider that the decision is difficult based on the very complex and intricate nature of all the considerations. We strive for the most effective medication for the targeted disability, keeping all of these in mind. Just wanted to share some patient experiences that I've had at St. Michael's Hospital and how we currently use neurostimulants, namely amantadine in our practice setting. We see about maybe 200 of TBI patients per year. Maybe we've seen since we started using amantadine January in 2016 to present about 106 patients. And we initiate when the patient is felt to be stable. That's usually at a 1 week post-injury. And we titrate the dose every 5 to 7 days to a maximum of 200 milligrams twice a day. I just wanted to highlight the positive outcomes with their use in terms of their GCS. However, we do see occasional adverse reactions such as agitation and restlessness, and we have seen on occasion one case where we thought this patient may have been seizing as manifested by some facial twitching. We have some upcoming research where we have some new pharmacologic agents that's providing novel therapeutic opportunities, which is very exciting, using psychedelics and anti-narcolepsy agents and orexin agonists, psychedelics such as psilocybin, which is not to enhance arousal as other agents are being used, but rather to enhance brain activity and complexity and consciousness content. Ketamine increasing arousal via the use of the neurotransmitter acetylcholine. And we see some novel orexin neurons in the lateral hypothalamus that has been studied, which has had some potential effective benefits in the treatment of disorders of consciousness. Certainly, we have many unanswered questions. We still need to determine what the most advantageous drug is, or drugs, could be a combination, the dose, frequency, and duration. Ideally, it would be nice to have an agent that's not sedating, not affecting the cognitive recovery, and has low side effect profile. Determine what the ideal timing is. Is it in acute or chronic stage? Is it for short course, lifelong? And conducting multi-center trials with standardized scales. Just to bring it back to our patient SH, we did at day 15, we did initiate amantadine, as we feel that it had the best evidence to support its use in this patient population. It's generally felt to be safe and well tolerated and appears to have benefit, as opposed to other agents which currently doesn't have quite as robust data, and we have to ensure that we individualize treatment. So in her case, we timed it once we no longer were on any sedative medications. And we optimized and adjusted her dose based on her response. We did up-titrate her to a dose of 200 milligrams twice a day. And after having been on amantadine for about 8 or 9 days, we did see that she did follow commands and open her eyes spontaneously, which was very exciting. However, due to extreme agitation, we as a team decided to reduce her amantadine dose, as no other adjunctive therapies were able to have her safely on that higher dose. And at this point, I'd like to look forward to answering any of your questions at the live panel discussion. And I wanted to say merci, grazie, and thank you for your time.
尊敬的4位史蒂文教授，大家好，也各位关心意识障碍的昏迷患者的爱心人士们好。我来自于复旦大学附属华山医院神经外科的吴旭海。那我跟大家汇报的题目是中国脑损伤严重意识障碍的患者的神经调控的促进治疗进展。我们知道，全球每年有数千万的颅脑创伤跟脑卒中的患者，这严重的患者。随着我们重症技术跟神经外科技术的提高，更多的患者得以幸存，那么也就是意味着更多的患者以严重意识障碍状态生存。所谓严重意识障碍，主要指昏迷、伪意识状态和无反应觉醒综合症，我们通常称为植物状态。我们中国的人口基数最大，那么这些患者中国是最多。中国每年有高达7万到15万的新增的严重意识障碍患者，这些患者给家庭跟社会带来巨大的负担跟挑战。那么如果促进治疗，目前临床没有特效的办法，那我们神经调控方法认为是最有效的，但是不是所有的患者都是能够促进治疗，所以我们如果去筛选，去准确的判断哪些患者是合适的，那么这是我们国内的学者是华山医院跟中科院合作的一项工作。我们利用结构化害语语义听觉任务范式的意识的评估系统，我们首次实现床旁可以个体化的准确的鉴定患者的意识水平，然后预迟患者的预后。那么可以传统的我们的行为学的预知准确率从47%提升到现在的87%。这样工作的意义为我们筛选适合神经调控出现的患者去建立适应症具有非常重要的借鉴的意义。那么我们国内的学者一些非常重要的工作，另外一项非常重要的工作就是利用人脸识别跟数字识别的脑气接口技术来鉴别不同的意识状态，包括植物状态、伪意识状态与认知运动分离，尤其是能够准确的鉴别认知运动分离状态，这也是为筛选适应症这个神经调控的适应症是非常重要的。那么我们国内的这个神经调控主要是分为无创跟有创的神经调控的促进治疗来临床实践。那么这份工作，那么以北京天坛医院的何江红教授在国内他这病例是最多的，他对基于电刺激的病例的有效率促进有效率达到34%， DBS 深部电刺激的有效率可以高达41%。但目前所有的这些治疗，包括国际上的神经调控治疗，我们现在仍然很难鉴别这些是神经调控的出现的效果，还是患者病程自然的恢复的效果。所以我们还需要意识机制的更加深入的进展，也需要更加严谨的临床的随机对照研究来探讨我们神经调控的治疗的有效性。所以我们现在希望能够建筑功能磁共振的脑影像的诊断的语音平台系统，也希望建筑于床旁的脑电的评估系统。这两个系统，我们国内的学者，我们华山医院跟中科院以及华南师范大学，我们建立两个平台，希望能够对于我们的临床的诊断跟鉴别跟预测建立适应症能够提供帮助。那么这个华山医院作为国家神经疾病医学中心，那么建立了意识障碍的数据大样本的这个数据库。那么这个单中心剂已经有功能磁共振的病例超过1000例次，有高密度脑电有超过400个例次，那也包括一些生物样本的这个样本库。那么我们国内的话，已经对于慢性障碍已经建立了诊断跟治疗与神经调控的适应症这些为我们的临床实践提供了一个很好的一个指导意义。那么从2020年到2021年2年当中，国内对严重意识障碍患者植入脊椎电刺的病例总共达到560例病例，那么深部电刺激植入的患者是64个病例。那这些患者是我们非常很好的一个促进实践，那需要我们更加关注的长期随访的长期的一个远期疗效。那么为了更好的实现我们这些患者的治疗，那么我们国内的学者利用高产量的功能磁共振、以PET、CT、PET 磁共振、脑磁图以及我们各种意识状态，除了意识障碍的患者以外，我们跟睡眠麻醉的状态，用不同的动物的模型，包括小鼠一个猕猴的模型来实现意识障碍的机制的研究，以及神经调控的一些实践的一些探索。那么所以我们在未来，我们希望能够在意识 障碍的机制，尤其是意识机制上面能够更加深入，甚至能够取得突破。在意识机制的进展的基础上，我们能够更加精准的对慢性意识障碍的脑功能检测，能够更加准确的实现诊断，然后分类，然后建立神经调控的适应症，并且针对不同的个体的损伤特点，能够建立选择更加适合的神经调控的出行治疗的方法，来更好的出行治疗。谢谢。
Dear colleagues, thanks for the opportunity to introduce the brain stimulation to cure coma patients in China. The story I would like to tell is a story of Shanghai coma afferent neurostimulation, namely scans, began in 2005. I'm Dr. Gui Gao from Shanghai General Hospital. In 2005, I contacted Dr. Aaron Cooper in North Carolina for the technical detail of right median nerve electrical stimulation. This is a transcutaneous electrical stimulation, and the electrical stimulation can be transferred from spinal nerve to spinal cord, and then brainstem, thalamus, and cortex. That is the injured brain. The very first patient treated in my department is a 5-year-old boy. He was suffering from TBI and fell in coma for 1 month. After transfer to my department, he received the right median electrical stimulation. This is the first patient received this kind of treatment. After 1 week treatment, the patient movement increased, and after that, the poor boy recovered very well. At the 4th week, that's 1 month after initiation of the treatment, the boy can walk, can run, and can play computer games. And 5 months after follow-up, this is a lucky boy, recovered very well. From then on, we started the coma awakening practice in neurosurgical ICU in Shanghai. We treated various patients of TBI with various etiology, including focal lesion and also some patients of diffuse injury. We published the results of right median nerve electrical stimulation for acute traumatic coma patients on Journal of Neurotrauma in 2015. And the result indicated that patients received the right median nerve electrical stimulation has the rate of regained consciousness about 60, and the proportion of patient regained consciousness in control group is about 46%. I believe we are not the only group in the world trying this simple technique for various neuroinjury disease. And from 2017, we started another multi-center randomized controlled trial on acute coma awakening using this electrical stimulation technique. We call it ACES study. Through this multi-center randomized controlled clinical trial, we try to identify the safety and the effectiveness of right median electrical stimulation on traumatic coma patients. This intervention will be initiated at the early stage, that is from 7 to 14 days after injury. The patient will recruited into the clinical trial, and right median electrical stimulation intervention will continue for 2 weeks. That means within 28 days, the patient will finish the treatment of right medial electrical stimulation. We collected the primary endpoint as the percentage of regaining consciousness 6 months after traumatic brain injury. Also, we collected secondary endpoints, including GOSE, CRSR, DRS, force score at different time points after injury, and also the duration of unconsciousness and mechanical ventilation, the length of ICU, and hospital stays. Currently, we have finished the data collection, and the preliminary analysis of the primary endpoint indicates that the patient received right medial electrical stimulation has a higher rate of regaining consciousness compared with control group, with a statistical significance. And we are working on the patient data sets to analyze the secondary endpoints. And I believe we'll publish the result of this study in the near future. So this is a story of scans in Shanghai. We tried to cure coma patients using this transcutaneous electrical stimulation technique. We tried to achieve a stronger clinical evidence to help more patients. And of course, we need to achieve target of shining the dark side of neurosurgery. Thank you. Thank you for your kind attention.
Hello everyone, I'm Dr. Fan, the director of the Brain Injury Center, BIC, Lenji Hospital. In May 2021, Brain Injury Center, BIC, was founded at Lenji Hospital of Shanghai Jiao Tong University School of Medicine, aiming to build a great medical, teaching, and research center of TBI, neurocritical care, coma curing, and nerve repair in our country. This makes BIC the newest independently operated clinical department in our hospital.
Before the BIC founded last year, Renji Neurotrauma Group has been renowned for the splendid memories and histories. Professor Jiang Jiyao and Professor Gao Guoyi as well were the outstanding ones leading the group, contributing to the International Neurotrauma Society, including holding the 10th International Neurotrauma Congress in Shanghai in 2011, establishing the only provisional level TBI institute in China, publishing important clinical studies in the Lancet Neurology in 2019 to 2021, and the leading 12 expert consensus on TBI management in China. BCI now has a young team with honor, full of energy and ambitions in saving TBI patients and improving their lives. This is Dr. Yang Xi, a member of the young group. It occurs to us that prolonged disorders of consciousness, or DOC, often follows neurocritical issues and pose huge burden to healthcare providers, to their family, and to society. Hereby, BIC proposes its commitment against DOC. One of our goals is to cure patients with DOC to improve their coma status.
Hello, I'm Dr. Yang Xi from BIC. We have already established a SOP in helping patients with neurocritical care needs arrive at a stable status. The great potential of neuromodulation, either uninvasive or invasive procedures, together with a series of integrated treatments, including drugs, hyperbaric oxygen therapy, and the like, in promoting wakefulness in prolonged DOC, has displayed their unique roles in our center. My brief is to orchestrate them into a comprehensive plan, thereby helping more patients and also helping more colleagues cure coma.
Our vision.
Our vision